I'm Katie Drago. I am a geriatrician at OHSU. I work inpatient. So I was one of the founding members of OHSU's Inpatient Geriatrics Program 8, almost 9 years ago, and did my training in internal medicine and geriatric medicine also at OHSU. So I've been knocking around the halls of Pill Hill for a long time. I am honored to be joined today by Matthew Sutton, who is a former OHSU survivor who has since moved on, but has been gracious enough to join us today and talk about guardianship. I'll let Matt introduce himself.
Yes, thank you, Dr. Drago. I'm Matt Sutton. I'm a licensed clinical social worker and a certified substance abuse counselor. I worked at OHSU in the trauma ICU for a few years, and I left OHSU for beautiful Hawaii, and I currently work at the Queens Medical Center in a hybrid inpatient-outpatient program that is designed to reduce utilization by addressing social determinant of health. And I also am a program manager for our state's police psychiatric hold program. So happy to join. And that's who I am.
Matt is as always has too many jobs and is being far too humble. He taught me a lot about guardianship and conservatorship in his time at OHSU. So we are even though neither one of us are lawyers ourselves, we've had a lot of experience with the guardianship system and clinical scenarios where guardianship has come up. So hopefully by the end of this hour, everyone will leave with at least a few more tools in their toolbox and hopefully a little more confidence and a little steadier ground when it comes to navigating these really complicated patient situations. So we are going to spend the next hour talking about guardianship and the Goldilocks problem, and really with the hope of identifying those clinical scenarios and fraught situations where guardianship may actually be the right answer. And hopefully in talking about it that way, that will kind of make it a little clearer for those situations where maybe guardianship really isn't the right answer. It's a tool in the toolbox, but it is not certainly the be all end all to every problem. So disclosures and conflict of interest. This really has little bearing on what we're going to talk about, but just want to make sure in case anybody knows this about me that I'm not hiding anything. I am a board member for 2 community nonprofits in the Portland metro area that serve homebound, cognitively impaired, other vulnerable adults, house call providers, which is a home-based primary care and hospice agency, and then Meals on Wheels people, which is our local Meals on Wheels chapter for the Tri-County area in Portland. But I do this out of the goodness of my heart. There's no money changing hands. So if I have a bias, it's that I love these organizations and the work they do for people. And Matt has no conflicts of interest to disclose. Again, by the end of the hour, here's what I'm hoping everyone will walk away with a little bit more confidence in. The ideal attributes for a potential guardian. And this would be true for a family, trusted, non-relative, or even a public or a private guardian. Highlight problems guardianship will not solve. Just again, sort of in the service of carving in and carving out, where is guardianship most helpful? And then hopefully fill our toolboxes with some viable alternatives to guardianship that can help people get their needs met without the sort of restrictive last resort of a court proceeding. So I want to start here. Does anybody recognize this shot, this photo? Got a yes. Feel free to come off mute too and jump in if you know where this is from. So this is from the Netflix show I Care a Lot. It's worth watching, particularly for this crowd. Yep, I found it totally disturbing myself. But it is all about this lady right here who is a private for-profit guardian. Fascinating, highly recommend it, but don't watch it at night. It will leave you with nightmares. This is the same actress from I Care a Lot. This is how guardianship is portrayed in the sort of civilian media. And then we counteract that with the sort of sad, tragic tale of Britney Spears and Jamie Spears and the Free Britney movement that I know Matt and I have talked a lot about over the years, and I'm sure everyone is familiar with. And even John Oliver has gotten in on sort of the perils and triumphs of guardianship over the last few years. Also, an episode worth watching, but don't watch it at night; it will keep you up. Um, and so, a lot is out there in the lay press about sort of the downsides, the pitfalls, the abuses, arguably, of guardianship and conservatorship. We could talk about that all day, but instead, again, we really want to focus on where guardianship can really be helpful for people, what it's geared towards and what it's really not. You all are ethics professionals, so I'm not going to languish here, except to say that in the state of Oregon, this is how we define guardians and conservators. If you have practiced in another state or in the future you will practice in another state, know that this language does not translate. In other states, everyone has a slightly different usage and convention and definition around what a legally appointed guardian is and what a legally appointed conservator is and what their scopes are. And so oftentimes these terms are used interchangeably, which arguably makes this even more confusing. But in the state of Oregon, guardians are empowered to assist with decisions about care, medical care, physical comforts like lodging, activities, work, et cetera, but not finances. So if someone needs sort of specifically assistance or support with their finances, that's where a legally appointed conservator comes in. There's also a payee, legally appointed payee, which is sort of a step down from a conservator. So again, complicated landscape. What's key to remember here, though, is that each guardianship arrangement, as it is specifically laid out by the court, is different. And so the judge and the court in these cases has authority to really, in a detailed way, carve out what are those exact areas that the protected person needs help with from their guardian or conservator. And so just because you've seen one person with a legally appointed guardian or helped, a patient and family through the process does not mean that you have a great understanding of all guardianship arrangements. It is new every time. So having the paperwork, when you even get a whisper that someone a case you're involved in or someone you're caring for might have a legally appointed guardian or conservator, your next thought should be, great, can you send me the court papers? Because that will have exactly the scope of the guardianship arrangement. So again, the courts craft these guardianship orders to be the least restrictive necessary. And that's because having a legally appointed guardian or a conservator really is a shifting of that adults, in particular civil rights, away from them and to another person. So it's a really, really big deal for someone to be adjudicated as incompetent in certain domains and needing the support of a guardian, because that is a statement that they are incapable in a durable fashion, permanent or long-term fashion, incapable of managing their basic needs, but also the abilities to assemble and associate, the right to vote, et cetera, et cetera. In the state of Oregon, we have been very, very clear in statute that protected people under a court-appointed guardianship agreement retain all of their civil rights unless they are explicitly carved into the guardianship agreement. And so this includes the right to assemble, the right to vote, the right to communicate with other people through whatever means that person wants to have access to their records, both legal and medical, to retain a lawyer and legal representation, and then the right to work or not to work. And some of you, if you're thinking about Free Britney, may be thinking like, wow, okay, I remember some of these becoming points of contention for Britney and her dad as part of the conservatorship agreement in California. different state, different rules. But these are the rules as laid out in the state of Oregon. I saw a question come across in the chat, but we'll actually touch on those right now. So when the clinical situation changes, so like decision-making capacity changes, requiring a change in the guardian's duties, the whole thing does need to go back to court. Only the judge, the court, can update or amend a guardianship or conservatorship agreement. So in the case of like severe persistent mental illness, where with treatment, particular treatments, there very well might be a restoration of, in whole or in part capacity and competency to manage all the domains of life. That guardianship arrangement can only be adjusted, redacted, rescinded by a judge. So that whole thing needs to go back to court. And it is a lengthy process for people trying to come out from under a guardianship arrangement. It's doable, but it is a long process, which I think if we go back to the beginning, also makes the stakes pretty high for people when we're considering guardianship, because it is something that's really tough for people to navigate out of if their situation changes. Please feel free to put more questions in the chat. Matt and I, when we have the sort of shift in big topics, we're going to check the chat and see if we can answer stuff on the fly. Otherwise, we're hoping to leave a good chunk of time at the end for sort of Q&A and discussion. So what makes a guardian a good option for a particular situation? And the subheading here is that incapacity, decisional incapacity, even if it's permanent, related to traumatic brain injury, dementia, other neurologic or cognitive conditions, does not automatically equal guardianship. I would argue, I think Matt and I would argue both, that the most important quality in this guardian-protectee relationship is listening. Guardianship and conservatorship is not about control. It's about partnership. Because again, the purpose of a guardian is to really make sure that the person is safe, that their very basic needs are getting met, that they're not being taken advantage of by lesser scrupulous people. But also to preserve, support, and maintain as much independence, both in decision-making and life, as is possible for that person. It's important to remember that people still retain the right to vote with their feet, which means even, and I'm sure we've all been in this situation where in the hospital or out in long-term care practice, that people, even though they have been deemed incapable to make a particular decision, are just hell-bent on saying, I am not having that surgery. I am not going to that doctor. I will not move out of this place. And that's what I've sort of simple-mindedly call voting with their feet. There is virtually no way to force someone to do something that they are dead set against. This is true even if they lack the capacity to make what we would consider a truly informed decision. And so the most successful guardian-protectee relationships are those where listening, striving to understand, and then supporting that person's priorities, even if we would disagree with them, is really at the core of a successful partnership. I call this presence, engagement, and understanding. Children are subject to legally appointed guardianships all the time. Arguably, this happens a bit less in the adult side of the world, but adult protectees are different from children. They have, in some cases, decades of lived experiences, prior life traumas, just other life chapters that inform their beliefs, their preferences, and their values, and these commonly persist in diminished decisional capacity. There have been some really heartbreaking stories that I think Matt and I could both tell you about people who had such traumatic childhoods that they just sort of decamped and disconnected from all the trappings of modern life. I knew one patient who preferred to live in the woods because just being around other people was so scary because of a long history of childhood trauma. And those patterns of decision-making, those beliefs and those values commonly persist even alongside mental illness and cognitive impairment. And so, really effective guardians and even financial conservators really make efforts to understand who is this person, especially if they're new to this person's life, not a family member or not a longtime trusted person. They really do have their work cut out for them getting to know the person that they're protecting, and then bring that understanding about the person into their daily work in medical care, in lodging decisions, in legal, medical legal or financially legal decisions. And so I've thrown some examples here on the bottom of the slide. I think and we'll touch on this a bit later, for us that work in healthcare settings, we are often subject to a lot of pressure from our own higher ups. I know I certainly have been on the receiving end of that. I know Matt has too. And I would bet money that most of you have been too. Um, and it puts us in a tense situation where we may understand why the person might feel more comfortable seeking care through an ER instead of going to a clinic. But our systems may not have that same degree of understanding. All right, I'm going to turn things over to Matt to go through some cases. Again, remember, this is the Goldilocks problem. So we're going to talk too hot, too cold, and just right.
Hi, yeah. So when we were talking about how to frame this, we were talking about how we can really best present this. So, case where guardianship was too hot, and by too hot, I mean people were just coming in like way too hot, way too quick with trying to create this really restrictive intervention. And I think the problem that we were trying to solve was essentially trying to stop somebody from wandering into the community. So I'll just give a quick overview of this particular case. So there's an older male with a history of alcohol use disorder, bipolar disorder, who's experiencing the first stages of dementia. He was estranged from his family due to the bipolar disorder and the alcohol use. He was also married, and he and his wife would move from city to city, just kind of in this transient way. They weren't homeless; they would find insecure housing in each new locale. And as they aged, his wife became his primary caretaker, just because with the dementia taking over, he was confused. And it got to the point where when his wife started experiencing medical problems and go to the emergency room, he would also go to the emergency room just because they didn't have a good plan for what to do with her when she needed to be taken care of. They would often spend most of their days just kind of like walking through the cities, walking through the community, spending time at the park, or just kind of bar hopping, doing this, that, and the other. His wife ended up dying. It was quite a traumatic death. She was pushed down and hit her head. So very sudden, very unexpected. He lost a significant proportion of his income that he was not entitled to after she passed away. So now he was experiencing houselessness. He could not. Sorry, is somebody trying to ask a question? No. Okay. So he could not independently execute rental payments on his own. He would often lose his keys to where he was staying. And he also got lost in new places. He had some medical literacy because of his work history, but he was not aware of his own needs. So he would go into AFib, and he knew he had to take medications, but he couldn't keep track of how many pills he was supposed to take or when he was supposed to take them. And he would often overtake his medications. He was also underserved, and we did not really know about what his needs were until he started coming into the emergency department almost daily. When he would come into the emergency room, we were getting unreliable assessments, meaning each time was different, depended on if he drank or the time of day. He did sundown, so that became an issue that made our understanding of the clinical picture a little opaque. Next slide, please. So the ED visits ended up becoming almost daily. We worked really hard to try to connect him with a family. There were no children around that wanted to be involved in the care. So we were able to find a nephew of his wife that was local, who agreed to become involved in the care. And we even tried having him live with this nephew, but he would be agitated. He was disorganized. There were toddlers in the home. So this really wasn't a permanent option, just for safety of the children. So we were able to get him placed into medical respite. But this was also tricky because he wanted to wander, and the medical respite had some pretty strict rules about who could leave, when they could leave, where they could go. Fortunately, he was not a fall risk, so even though he was on these anticoagulants, it wasn't really a risk to just let him leave and wander and do things, because like we weren't worried that he would fall and hit his head. So one of our interventions was just to let him go and get familiar and acquainted with this new neighborhood. Some staff were not really on board with this, and he would get agitated and start throwing things and become just really kind of impulsive and unsafe when they tried to restrict his movements. We ultimately determined that a congregate living situation was not in line with his values. He was older, he just wasn't really used to having this kind of restriction and these boundaries in place. Next slide. The physicians that were managing his care in the emergency room and ultimately the primary care provider were hoping that maybe we could pursue guardianship. And the problem they were trying to solve was just to keep him off the streets, put him in a locked facility, and he would not sign himself into such a facility. So the nephew paid independently for this. So there were financial resources that were available. And the attorney ultimately said, this is going to be a really tough case to prove just because there's not a reliable assessment. We had multiple data points that he was able to use, but we ultimately decided to not pursue the guardianship route just because it was going to be lengthy, it's going to be expensive. We looked into alternative options, which were to have the nephew be really involved with care. We got a geriatrician involved who followed for quite a few months and was able to sit down with the nephew and with the patient and hammer out a really strong advanced healthcare directive. We were able to get the nephew to be the representative payee, to manage the finances, to pay rent. We ultimately got some chore services in place with a nurse to come and visit, also to help with the medication management. Let me see where, sorry. Let me zoom in. So this progressed with the heart failure. Our gentleman ended up with end-stage renal disease, and it was ultimately decided to let the patient forego dialysis. It did not seem consistent with his values to spend the rest of his life in a dialysis clinic. And so he ended up living the rest of his life independently, able to just wander through the community until he got too sick to really wander, and he went into hospice care, received high quality hospice care, and was able to address his dying wishes, his last wishes, and actually reconnect with his children, and died a really good death. Instead of being locked away in this facility or in this memory care unit where he would have been constricted to just a few rooms in a hallway. So another case where guardianship was too cold was actually somebody who needed a guardian. It was a middle-aged female with schizophrenia, intellectual disability, and substance use. She was completely estranged from her family. We could not locate family. We could not, through multiple avenues, we tried to locate family, just could not do it. She was actually managing okay while she was living with a significant other that helped her get off the streets. But again, opaque history here. Either they broke up or he ended up incarcerated. So she returned to houselessness, living on the streets. This was pretty destabilizing to her, but she did have survival skills. She was able to complete transactions to get her nutritional needs met. She knew she had to take medications. She just necessarily wasn't aware of the best way to do it. She was connected to our highest level of outpatient mental health care. And she actually was agreeable to taking a long-acting injectable, and she would seek her refills for her oral medications in the emergency room. She was assigned to a public guardian. The public guardian did not know her, did not take any efforts to really get to know her history. Public guardians are often overworked. They are just assigned these cases that they have no idea about who it was or even how they ended up with the guardian. And the guardian was just really uninvolved. And the case manager was also fairly uninvolved too. The case manager would defer to the guardian would defer to the case manager. There was no strong attempt of engagement from the case manager. And the attitude was often, it won't matter. She's just going to do what she wants anyways. Next slide. This often ended in a finger pointing game. Frequent ED visits, and the hospital was just concerned about who to contact for care planning. The primary concern was just keep her out of the hospital. So really, because we had this guardian involved and we had this case manager involved, nobody really got to know the patient. There were the case manager and the guardian did not have aligned patient care goals. And in fact, we discovered there were not even any patient care goals. It was just really, how do we keep her out of the hospital? Her strengths and preferences were overlooked. She was homeless, but socially that's a problem. But in this particular case, focusing on the individual, who was it a problem for? It was not a problem for the patient. She did not care that she was homeless and living on the street. She seemed just happy sitting on a street corner. In fact, we would just pass her on our way home from work or on our way to work, just sitting out there looking happy as a clam, just kind of like la-da-da. She did not care. So that was not a problem that we needed to solve. She did have survival skills, so there were no markers for malnutrition. There were no visits for sexually transmitted infections, no physical assaults, no sexual assaults. And she would actually seek shelter to get off the streets in the times of her most dire need, like if she had an illness or if there was inclement weather or anything of the sort. And she often engaged in health promoting activities, maybe not the best way that we would want to see it happen as a system, but she would visit the emergency room when she had symptoms of physical illness, like would report subjective fevers, she'd have a cough, she'd have stomach pain, etc. And she was agreeable to take her medications. So the guardian wasn't even really needed for that. And she also engaged in sobriety. There were periods of sobriety. So she knew what she needed to take care of herself. She just necessarily wasn't able to navigate the system in a way that was cost effective or that was the most stabilizing for her or most optimal for her. We still don't really have good resolve for this, and the current plan is to wait until she shows signs of sexual exploitation or engaging in sex work, or there's other victimization. So definitely needs a guardian, just needs a different kind of guardian. So a guardian is helpful, just not always the best option, best use of resources. Next slide. And now here's a case where the guardianship was just right. We had a young male come in with a traumatic brain injury. We knew that he would not recover enough to manage any aspects of his life, really. Like he might be able to say, I don't want that food, or I don't want this particular TV show, but he could not say if he could take medications. He could not even say if he was hungry, really. So his parents both petitioned the court for guardianship when he was in the hospital. I see your question. I'll get back to your question, Phoebe. So when he was in the hospital, at least one parent was in the hospital daily for education, for care planning. And when they couldn't be there, they sent a trusted proxy in their place. This was not due to a mistrust of the medical system or anxiety that something would happen in their absence. This was them really wanting to be involved in the care and understanding specifically what his ongoing needs were from moment to moment and long term. So they had an astute understanding of his condition and his prognosis. And when it came time for care planning, they actually were like, we knew him as a child, we knew him as a teenager, we knew him as a young adult, but we don't know him as an adult. And so they utilized friends and family members that he was close to understand what his values were and to understand like what maybe he would choose for himself. So they really had it down. They really understood what it meant to be a surrogate or a healthcare proxy. They were also aware of their limitations for providing his long-term care needs. They were semi-retired. They knew they couldn't be with him 24/7. They knew that they were not physically capable of turning him, of lifting him, of helping him to the toilet. And they were very proactive in making sure that resources were in place and that the appropriate facility would be found. And they knew that things might change, that he might need a higher level of care, or maybe he might even, progress slowly, incrementally over the years to need a lower level of care. So this was just a really strong example of when a guardianship was just the right fit. There are some questions though that I think we might want to address. So who pays the lawyers? Is it usually just one lawyer in front of the judge, or are these lawyers representing competing views? I think that varies. It's usually quicker if somebody gets a private attorney and they pay out of pocket. Different healthcare systems have different resources. At my hospital, we do have a legal team that will do the guardianship process, but that is a very lengthy process, and that is when delay in care might happen. I can't speak to how OHSU handles it. I don't know if Dr. Drago, you can speak to that.
Yeah, OHSU does have some charity funds. There is a supply of money to support uh, cases where there is a petitioner, there is a family member, a trusted person that is willing to be the person applying for guardianship, but may not have the financial resources. There is money for that. And so we go through case management and our social work team to access those funds. For folks that are unbefriended and there are no resources, those are the most challenging cases that in the past have gone through the Office of Public Guardian, which I'm we're amongst friends here, so I imagine all of you know OPG is incredibly overworked, overfunded or underfunded, and for a while, Multnomah County Office of Public Guardian wasn't even taking new referrals. So the system is broken in that regard. And those honestly are questions that as a provider, I tend to let our social work team navigate along with case management because there are resources. I know this is also true at Providence, and I believe this is also true at Kaiser as well. So if you have questions about what exists in your local institution, in other parts of the state beyond the Portland metro area, definitely ask, sit down, explore with your patient relations team, care management, social work team, because they will know what is available and where the gaps are.
Another issue with the charitable legal representation is part of the guardianship process is you have to identify anybody who might have an interest in being the guardian. And if you pay privately, the attorneys that do private pay often have a team that can do that. And if you are part of a healthcare system, that work often falls to the social worker, who is also overburdened sometimes. And that process could take a very long time. It could take up to 45 days before the legal team is satisfied with the search being exhausted. And then also people have to be served papers that guardianship is being petitioned. So there is a time difference between privately paying and charitable coverage for guardianship. In case example 2, what would change if that particular patient was victimized? We don't really have a good plan. That would be something where we just start having more meetings with the guardian and the case manager to see what we need to do to keep that person safe. And since nobody really knows her or what her values are, there would be no strong answer or no good option. It's just kind of sad that that's what we have to wait for before people start to be more concerned about what the interventions will be and the care planning that will take place.
I want to touch on Helen's comment too about the Just Right case. You're right. There were some real advantages that family had, right? Loving parents, invested friends and family that could relay, like, this is what we know about him and his thoughts and wishes. And you're absolutely right. That is not always the case. I know we're seeing a lot more unbefriended people. We're seeing a lot more people that really, you could argue, society has left behind. And chickens are coming home to roost by the time they end up in our acute care settings. Neither one of us is going to argue that the system is perfect. It is far from it. But I think there are opportunities where if we drill down truly in those most complicated of patient cases, it into like, what is the problem that we're trying to solve here? Kind of like case number 2 with the woman who arguably is succeeding at being homeless, right? Homelessness is not the problem for her. The problem is that she needed an advocate for the way she wanted to manage her healthcare issues and finding creative solutions for how to help support her in managing her medical conditions. And so that would be the ideal role for a guardian, not necessarily focusing on lodging. Um, and yeah, we'll touch on in a few slides about the complicated discharge situations because I imagine that is what bothers all of you. It bothers me too. So thank you for throwing questions in the chat. Please keep them coming. So what now? Really, the top line takeaway is that guardianship is a tool, but it's a tool amongst many. One thing that I know our geriatrics team does that actually Matt taught me how to do, and I know our psychiatry teams and other specialists that commonly are involved in these patients, we try as much as we can to do this, is to take a really, really deep history. For anyone who's facing a potential guardianship situation, or you feel like maybe heading in that direction. Moving beyond just sort of the typical medical history and getting something closer to a life story, understanding important life events. I've been surprised by prior military service, prior sexual trauma, lots of adverse childhood events, things that I wouldn't necessarily have explored had I just limited myself to sort of a standard medical history. Because the goal is to really understand sort of what the person has been through and what from those experiences might be driving them to make some decisions that we might look at as putting their safety and their health in jeopardy. Also getting an understanding too for who are their safe people. I'm betting that more than a few of you in your ethics and other patient care roles have met people for whom the most trusted person in their orbit was actually their bartender. That's a case I had years ago when I was a resident. And we actually were able to have this cognitively impaired patient say, yes, I want this person, his bartender, being the one making medical decisions as a verbally appointed surrogate decision maker. And the bartender was willing because they had been friends for decades, and he actually knew a lot about what this person, what was most important to the patient. And we wouldn't have gotten there again had we not explored a bit more about this man's life. I think it's also worth noting that this is a process. This is never a single visit. So even though I know my bosses are probably listening to this and thinking, why would you say this, Dr. Drago? But oftentimes these patients are frequent flyers in the ER, in the hospital, in many hospitals in the same region. And putting together the story is a process that can unfold over multiple visits. And so, of course, this highlights the need for really good documentation that is really accessible, which if I had the solution to that, I wouldn't be here with you. But don't expect, I think it's too much to expect from any interprofessional team or ethics service that we're going to have this all figured out in a single hospital stay or a single visit. That is the exception, not the rule. And then use collateral history and the entire interprofessional team. One thing that I never cease to be amazed at is the ability of the chaplains and the pastoral care services to really get some incredibly useful information, nuggets about people's lives and what's most important to them, just from usual pastoral care visits. And I know sometimes as physicians and nurses and rehab specialists, we don't always think about the chaplains as being important investigators into important history and exam findings even for these patients. But don't discount volunteers, don't discount chaplain services, other folks that you may kind of have siloed in distinct areas. Work your whole interprofessional team for these patients. I also want to use this moment to point out that as adults, we have the right to make bad decisions. And this remains true even for people with marginal or impaired decision-making capacity. And so particularly for older adults, we find ourselves in the tension between safety and patient autonomy. all the time. This comes up all the time for people with dementia that may be living independently. Maybe they are approaching a point where they shouldn't be living independently anymore. But that there is just this inherent, very common inherent tension between the principles of safety and patient autonomy that honestly are never navigated the same way in patient cases. It really does depend on the person, their support circle, their lived experiences. But that I would almost expect that at some point in the course of a story of dementia, that tension will come up at one or more points. Some other tools, other alternatives that we may have. I know some of you may be looking at this and thinking, I don't remember the last time that I had access to really intensive care management. You wouldn't be alone. Again, the system is not perfect. It is not perfectly resourced, but always thinking about like, are there ways through supported housing? Are there ways, like a supported independent living building, which actually Central City in our area operates a lot of. And there's other organizations that offer this sort of support where there's embedded services for people to help with navigating the system, making sure they get to appointments, all that stuff. That may actually be a more reasonable balance for certain patients. Investigating what's available through OHP, through other Medicare CC or Medicaid CCOs, through other alternative payment models that maybe the patient may be a part of. So working your care management team, working your social work team, asking some of these questions about like what exists through their insurance carrier, through their Medicare, through their Medicaid, what exists through county support teams, if they have a county caseworker. Just exploring truly what's out there, what's been tried, what hasn't been tried is always a really useful experience. Sometimes, maybe more often than not, there's not a great option, but at least we know we will have exhausted everything we had before getting to the point of pursuing guardianship.
Yeah, and to add
Oh,
on
go
to
ahead.
that, with the intensive care management and case management, something that might be helpful is asking yourself, what problem are you trying to solve with guardianship? And having your social worker or social support services look into what resources might be available. And it might be, you might have to be creative. You might have to, like Katie said, you might have to tap into your insurance company. You might have to tap into the natural support. You might have to tap into the neighbors. Meals on Wheels, like sometimes, like what is healthcare? Sometimes it's just having food. Sometimes it's just having somebody with, sometimes it is just having access to their housing because they get lost. And these are just those overarching problems, the social determinant of health needs that a guardian might not be the best one suited to fit. And you just have to creatively think of community-based solutions.
Mhm. I want to put in a plug actually for our local Meals on Wheels chapter. Remember, I am on the board. No money changes hands, but I am lucky enough to be in a position to know the breadth of services that are provided, and it's not just meal delivery. They actually have some care management supports through the main office of Meals on Wheels. They have contracts with organization contractors in town that will do home repairs for people where if there's issues that are posing like distinct safety concerns in their living environment, we'll clear blackberry brambles, we'll do basic yard work, we'll actually provide pet food and pet support for people that are homebound that can't get out and like walk the dog or get pet food. So yeah, don't underestimate some of the community-based supports that are out there. Meals on Wheels is also really good about unearthing issues that people are experiencing and then connecting their clients to other community support services through organizations like Project Access Now and other groups. So work your social workers because they may have their fingers on the pulse. Even just using these extra eyes and ears around what we argue might be an unsafe living situation can actually be the most powerful source of information gathering on the ground. Because again, these are problems that are usually not solved in one visit to a hospital or one admission. And so I definitely have been in the position of needing to discharge someone back to a situation that I knew in my gut they were gonna come back and it was only a matter of time. But what we did to hopefully set ourselves up for success the next time is deploy as many eyes and ears on the ground as possible, including adult protective services. Again, overworked, underfunded, but can also be really effective boots on the ground to see how someone is functioning in their natural habitat, because it may actually be a little bit better than we see or we think in the environment, or it may be a lot worse, and then they actually have cause to act. So yeah, so that sort of intensive care management, community-based supports can actually be really helpful investigatory tools to help add to the story. So, what about the hesitant inpatient provider? I know I've been in the position, I know all of us have probably been in the position where your gut is screaming at you that, like, yeah, I think this person or this family really needs a guardian. That's the appropriate route here, but the roadblock is a specialist or an inpatient provider that is not willing to make a diagnosis that would qualify to the court for as like a severe persistent mental illness, dementia, so on and so forth. We as providers get trained that those are not diagnoses that you want to make when someone is acutely ill, or injured, or even in the hospital. A hospital is not a steady state for any human person. So we are trained, even to put up some resistance to making those diagnoses in the hospital. Um, that's a really common thing. I know I have been on both the receiving end and the delivering end of that message. Because it's a tense position. It's a really uncomfortable, tense position. What I tell myself and what I advise other people is that that admission, that chapter in the hospital is just one data point in the patient's overall story. And so, our job, even if we're not comfortable making a diagnosis then, is to gather as much collateral history as we possibly can, create as much hopeful institutional memory as we possibly can. Because if that person is truly unsafe in the community and truly in need, they will be back. And then that's another opportunity for us to gather more information, add to the story, and then maybe it actually makes a diagnosis much more clear over time. And we'll break down some of that intrinsic hesitancy to make a diagnosis like new onset schizophrenia or dementia in a hospital environment. I also really heavily lean on occupational therapy. In the state of Oregon, OTs are qualified mental health professionals. That's part of their licensure and their scope and their training. So, as a geriatrician, I actually rely on them a lot for functional assessments. Those functional assessments that actually have a lot to do with cognition, executive function, planning. They even have special tests for financial management that we can do to help bolster or clarify whether someone is really in need of a payee or a conservator. They can do a lot, and we underutilize in general the scope of occupational therapy. They're particularly helpful too in behavioral health admissions and where there's concern for undetected or sort of newly blossoming significant mental illness. So bring in OT earlier than rather than later. Let them know where you are, the clinical questions you're thinking about, and even as an ethicist, if you're doing an ethics-based consult, you can recommend OT for particular assessments. In general, they are more than willing to help out. And then again, consciously discharge from that admission where there is a hesitant provider with as many supportive eyes, ears, and hands as possible, including adult protective services. Again, more information lends clarity. What about the languishing discharge? I imagine some of you are like, oh my God, you two, get to the thing I really care about, which is this. This is a huge, huge, huge source of pressure for all of us. And I don't want it to sound like Matt or I are downplaying the pressure that all of us are under for these patients. It feels like more of these folks are in our hospitals now than ever were 10 years ago. That's been my experience. That's been the experience of the whole geriatrics team and psychiatry at OHSU, and I'm sure it's true everywhere else across the state. This sets us up as sort of ethically minded providers, maybe ethics consult providers or specialists that deal with vulnerable patients. This sets us up for huge moral injury because the system is broken. Oregon has the fewest hospital beds per capita. Our Office of Public Guardian system is fractured on a good day and completely non-functional on a normal day for patients. And this is a huge problem. It's been brewing for decades that is not going to be easily solved quickly. And so the way I think about moral injury is being a sort of, conscience-minded person wanting to do right by people in a system that is not set up to help support us to do that. And this is the definition of that kind of moral injury. So what I find myself doing is setting expectations, both for myself, for my partners, and for the rest of the care team. That guardianship, if we're thinking about it, again, it needs, ideally, would be the right solution for the right problems to solve, as we've talked about, but also letting them know this is not fast, it is not easy, it's not cheap, and it may not actually solve the problems that we're seeing. And then even sending that message up through the chain of command, through the hierarchy of care management, up to the chief medical officer or whoever is sort of in your clinical service line leadership, that these cases are not easy. This takes time, and oftentimes we're at the mercy of external systems of care beyond our health system. Work with your interprofessional team, work all the specialists and all the disciplines to the top of their expertise and top of their degree. There's lots of expertise that we're all swimming in every day that we don't always take advantage of, or sometimes things are moving so quickly that we forget to take advantage of it. So take a breath. Remember, you're never alone in caring for these patients. You've got people that you can turn to, even just to unload some of that moral injury. And then take the time while you're waiting, inevitably, for things to happen, to just be present with patient, family, and their trusted people. Coach them on what and how they can step in, areas that maybe they would be willing to help support the patient short of guardianship or some sort of legal arrangement, and or preparing people for what it means to function as a really high quality guardian for that person. Guardianship is filled with pitfalls. This is not an easy landscape. And when Matt and I were going through and putting together these slides, we kept coming back to these themes that, again, the system is not perfect. We oftentimes are walking on ledges that we could tip over, or the patient could tip over at any time. And so much like diagnosing learners, where you want to diagnose your learner to see where are you struggling, where can I most help you? Diagnose your system, diagnose your patient situation. What is the issue here? Is it an evolving mismatch between the protectee, the guardian, the trusted people, and the care team? Do you have a knowledge gap amongst the care team that's navigating the situation? Do you have a too hot or too cold guardian, or medical power of attorney, or legally or verbally appointed surrogate decision maker? So use your sort of diagnostic skills sometimes to diagnose the situation, identify those pitfalls, and then it makes it, of course, a little easier to stay out of them. But overall, these situations are hard. There is no one size fits all right answer. And there is a huge amount of moral injury that comes from these situations. I really appreciated Kayla Tabari in the plenary talking about moral injury, burnout, and compassion fatigue, because if you find yourself mired in a lot of these situations, it's almost a guarantee, and is definitely something we're all dealing with. But if we come back to what we know, right? Listening, striving to understand, acknowledging our limits and setting expectations around what the system is capable of, what we are capable of. Those, at least in my experience, have been really helpful in helping protect me from the burden, the heaviness and weight of these cases. It's also worth preparing people in the system that guardianship is not a finish line, like sometimes we feel in the inpatient space. It may feel that way because maybe it's the thing that we need in place, or the wheels turning before the patient can be discharged, which we naturally see as a finish line. But from the patient's perspective, that's not a finish line. That's a beginning of a next chapter. And so potentially too, that can help address some of that moral injury if we focus on like the future, making sure that we're doing everything we can to help that patient thrive in this new partnership. I want to leave, well, I didn't leave as much time as we'd hoped. I'm sorry about that. But you're never alone in caring for these vulnerable patients. You've always got lots of people around that you can call on, even just to run cases and make sure, like, am I missing something? Don't underestimate the power and support of your colleagues and other experts at your institution, at your county level. You've got help. You're not alone. This is our last slide, I promise. I'm checking the chat right now. Let's see. Oh my gosh, this is so wonderful. Okay. The dignity of risk. God, I like that. Melissa, my concern is for ambulatory patients who may lack capacity for complex decisions, yes, but have capacity to tell you who they trust. Sometimes they choose their caregiver. Melissa, you're raising a really good point. How many of you knew, and you don't have to raise your hand, but that licensed caregivers that are like paid through the state or paid by a facility, they legally are barred as serving as a legally appointed surrogate. So like, and this comes up a lot in adult foster home living situations where the resident might say, well, the person I trust is, Christina, who cares for me every day. That person is legally barred from being that person's appointed surrogate because of the conflict of interest relationship. That is tense. Those are tense situations. Usually what I recommend in those situations is I say, that's great. I'm glad this person is a really safe person for you. Who else is out there? And then I try to craft a situation where it's a decision-making team. So maybe that caregiver can be a part of the team, but the actual, for medical legal purposes, the surrogate may be the other person, the friend, the family member, whomever. But logistically, when that group is making decisions on behalf of the person, they're doing it as a team. So that way we're not in the position of saying, well, no, you can't have that person, and risk eroding further trust with that person. Oh gosh, Melissa, this was just people with disabilities have right to access care, and yet this appears to be a concerning gap. That is true. That really is true because sometimes the caregiver may be the only and best trusted person. Again, I think this is another downfall of the system that hopefully time will correct. Another question here. Several patients get discharged from hospital to a care facility, cases with delirium and mild or early dementia, lucid enough to express decisions, and once delirium is fully cleared that they do not want to stay at the facility. They were ambulatory with at least somewhat intact ADLs and IADLs. Family might have felt relief when they were in a facility and felt unable to care for them at home. This brings up lots of anguish and confusion, that when they're stating they want to leave, their wishes would get ignored or deferred. Those are really, really tense situations. What I usually advise is a coaching session with the family, to sit down and give them the venue to get out their concerns, usually around safety, sometimes around resources, caregiving resources in the family. And then I focus on bringing up the fact that, like, I hear you. This is always a concern, right? Always that safety, autonomy, tension. Our first goal should be trying to explore what's out there to meet everybody's concerns. So what can we deploy? What does the person have access to or the family have access to that could make home safer? I'm imagining it's home. Make home safer, but also support the person in being where they want to be. I know there's a Medicaid caregiver funded crisis right now, that we don't have enough bodies and people. There are always going to be logistical barriers, but if we even take the time to explore that with the group, and if we realize that those things are not feasible, then maybe we can actually come to some consensus, right? Going through and exploring all the options, coming to some consensus that maybe people won't like, but at least they'll understand. Um, there is sadly not a perfect, like idyllic solution to everything. Let's see. There's an adjustment period where facilities try to get people to settle in that seems ethically complicated. Yep. Um, Matt, you wanna tackle this one?
uh, yeah, no, I mean, I think that's where the coaching and education and really deferring to what the patient's overall goals in life and how they live their life are, and helping the family come to understand that there's going to be some level of risk that we cannot fully address or mitigate through guardianship or through restrictive intervention. So it's just really meeting where the family's at, where the patient's at, and like avoiding that moral injury that comes with that ethical dilemma.
Yeah, I wish I had better answers for all of these questions. In our final, oh God, our minute over, I just want to say thank you from the bottom of our hearts for all the wonderful work that you do on behalf of vulnerable people. And please remember that you are by no means alone. If there's ever anything that you need or anything that we can do, please reach out. I'm here in Oregon. Please reach out to me, my partners. But you've got partners. You're never alone. Thank you all. Enjoy the rest of the
Thank you.
conference.